So we've covered a lot of important ground with arterial blood gases. Here in this video, I'm just going to do a quick summary and highlight what's important from this concept from an exam and from an application perspective. So again, with clinical data, first of all, we got to see which category they belong to. Does your case or your clinical vignette or question talk about hypoventilation? Does it talk about hyperventilation? Okay. If it talks about hypoventilation with opioid drug use or asthma or COPD, I am looking at higher PaCO2 and lower pH and symptoms of drowsiness. Okay. And I am looking at respiratory acidosis. Okay. You can then further tease out whether it's acute or chronic by looking at bicarbonate. If the bicarbonate is not high and hasn't had time to compensate, then it's acute. If the bicarb has compensated, it's chronic. Okay. Let's see if the question has hyperventilation. Is there anxiety? Is there aggressive ventilation in the question? Is the PaCO2 down? Is the pH on the higher side? Is the patient agitated? Okay. If yes, it's respiratory alkalosis. Okay. Bicarb. If bicarb hasn't compensated yet, it's acute. If the bicarb has compensated, it's chronic. How do you treat respiratory acidosis? The definitive treatment is to correct the breathing issues or the hypoventilation. And you can do it with intubation and ventilation therapy, worst case. If it's hyperventilation, again, we manage the underlying issue if it's a pathology. And again, it's fine-tuning and correcting with intubation and ventilator therapy. Okay. Again, one can have issues related to metabolic side. And generally, either you're given two conditions. You're losing bicarbonate because of diarrhea, in which case you actually have a normal anion gap or no anion gap metabolic non-anion gap metabolic acidosis. So you have low bicarb and low pH. You treat the diarrhea. Okay, treat the diarrhea. Okay. Again, you can also add acids to the mix, and we talked about mud piles. How do you manage this? It's underlying diseases that need to be managed. And again, the bicarb is going to be low and pH is going to be low. The difference is going to be the anion gap is going to be high. And that's going to be high anion gap metabolic acidosis. Okay. On the other end of the spectrum, you can have metabolic alkalosis, which means the pH is going to be high and the bicarb is going to be high. And it could be because you've lost acid on the metabolic side and could do it by vomiting or diuretic therapy. And again, the way to correct it is normal saline infusion and treat the underlying condition. And the way you diagnose it is by looking at urine chloride if it's less than 20. Again, note diarrhea, vomiting, and diuretic therapy all dehydrate you. But diarrhea causes metabolic acidosis while the rest of them cause metabolic alkalosis. Okay, you with me on this? And of course, you can have gain of bicarbonate, and again, it could be hypertension or other disease. And again, the goal is to actually treat the underlying disease. Now, the vomiting and diuretic and dehydration conditions where you lost acid, that can be trained by normal saline infusion. And again, that's volume responsive or chloride responsive metabolic alkalosis. This one, where the urine chloride is greater than 20, and it's because of the gain of bicarbonate. Okay, that is not treated. If you treat it with normal saline, it's not going to actually correct the acid-base disorder. So that's chloride-resistant metabolic alkalosis. Okay. Last but not the least is PaO2. And again, if it's less than 80, you have hypoxemia. It does not change acid or alkalosis status, but we need to correct it. Remember, we corrected it using certain maneuvers. So that's something really important to know as to how the question containers are going to be there. Okay. The next thing that's really important is how does the pH change with my intervention? So if we need to change PaCO2, I can go up and down on the respiratory rate or up and down on the tidal volume. If I go up on the respiratory rate and or I go up on the tidal volume, I go down on CO2 and vice versa. And if I go down on CO2, right, I go up on pH because there's going to be more acid. If I go down on respiratory rate and tidal volume, I go up on CO2, I go down on pH because I have more acid. This is very, very, very important. This is how most of the questions are coming on high stakes testing, on boards and with HESI and ATIs and a bunch of folks there. Okay, PaO2, go up on FiO2 and PEEP and you're going to up the PaO2. Okay. If my pH is down and my bicarb is down, how can I compensate for it? I need to go up on my pH. That's how I need to compensate. So on the respiratory side, I need to go up on the pH or I need to go down on the CO2 because I need less acid. And I do that by, how do I go down on my CO2? I go up on my pH, I go down on my CO2 by increasing my respiratory rate and increasing my tidal volume. I'll blow off more CO2, I'll have less acid coming from the respiratory side to compensate for the metabolic acidosis here. Okay? Make sure you review and you're able to apply this. Okay? And then we did the abbreviated shortcut approach to arterial blood gas analysis. Step 1, pH. Is it compensated? And is it acidemic or alkalemic? Step 2, respiratory side is bringing acid or alkalosis. Metabolic side bringing acidosis and alkalosis. Step 4, match step 1 with step 2 and step 1 with step 3. This helps you determine who's the culprit and who's compensating. And last step is add PaO2 interpretation to this, which will then tell you whether there's hypoxemia or not. So anything less than 80 is hypoxemia. Okay, and that's acid-base disorders.